Okay, everybody. Well, welcome. So as we were getting started, Mohammed was just sharing some insights that he had on the USMLE CK, I believe, and how there's more quality improvement. Is that right,
Yes,
Mohammed?
yes, they increased the percentage of questions on quality improvement, safety, all these. Yeah,
Yes, I saw they made those changes on the exam. Yes.
Wow. When were those changes made? Was it something? It sounds like it was
It,
something recent.
they were starting to
yes.
incorporate these questions increasingly with every year, but November of last year was the date when the exam actually changed. There's a new version, they call it, with, yeah.
I see. Okay. Well, yeah, I mean, so that's very interesting. I think I think it's for good reason. I think
Yeah,
that what happens is when you're in training, you get trained in medicine, right?
yeah,
But then what happens is then you start practicing, and there are a number of things that you encounter that as physicians we really got no training on. And I
yeah,
think quality improvement is one of those things. I think one of the consequences of that is that, if someone says, oh, Dr. So-and-so, we're working on these quality measures and we'd like your help in improving these quality measures, they may ask for your practice, for you to actually adjust your practice, how to change your
yeah,
practice somewhat. And so as physicians, what happens is if someone comes to us and says, hey, we want you to change your practice, your natural inclination is like, just back off,
yeah,
So, and that's at least partly as a result of not a lot of, familiarity or introduction to what quality improvement is.
yeah,
So yeah. The other thing is we may not get training in this like finance, and when it comes to when it comes to things like that, if physicians go into healthcare administration, finance is something you need to brush up on because you don't. That's the other thing is someone says, "Oh, Doctor So and So are, you know, we're running a loss. Here we have decreased revenue here," and then as a physician, you're like, just back off. Don't
as
don't
well,
talk to me
yeah.
about
You
that.
don't know,
I'm
yeah,
yeah. It's like I'm taking good care of patients. All right, you don't need to tell me. So anyway, and it's actually interesting because as physicians, we're expected to have good leadership characteristics, and that's how people become a chief resident and things like that. And leadership training isn't something specific, uh, or it's not a specific training that you get during medical school and residency. So those are all things that you know you kind of learn as you go along. But I can see why, for quality improvement, there's a recognition to increase that material. So,
yeah.
and that's what today's topic is. So, all right. So I tell you what, I think I actually like quality improvement a lot. I'll tell you a story actually. So we volunteer at the Medina Clinic, right? Medina Clinic, it's a charitable clinic. We see patients who don't have insurance. Okay. So one of the things we wanted to do was to improve how we were doing with preventive measures. And basically like, there's not necessarily preventive measures, I should say. Our goal was to improve our preventive health care, our preventive care.
Okay.
So, for example, we felt that, well, we have a lot of female patients who qualify for breast cancer screening and are really screening for everyone. Because, it's a free clinic, they're coming for something specific. You try and help them out on a charitable basis, and that's pretty much it. But there's more you can do for them. So we felt that we could probably improve our breast cancer screening. So we decided at one point to have like a checklist of different preventive services for patients. And for these preventive services, we one of them was, have you gotten your mammogram? And so there was one patient who came in for, it was like a headache, okay, if I recall correctly. So she came in for a headache. And by the way, her son actually volunteered at the Medina Clinic too. Her son volunteered as a Spanish language translator. So he's a very, very good kid, very good kid. So anyway, this is his mom. So mom came in for a headache, and we're like, okay, address the headache. And then we go through our checklist and we say, oh, okay, have you had this? Have you had this? And, oh, have you had your mammogram? She said, oh, no, I haven't had one. It's like, oh, you haven't? Okay, well, let's see if we can help you get one. So we set her up for a well woman exam in our office. So she got that. And then she got her mammogram, and the mammogram was abnormal. And so we said, okay, well, a lot of times it comes up abnormal. We'll get some follow-up imaging. So we're like, okay, then we get some follow-up imaging. It was still abnormal, and they recommended a biopsy. So we're like, well, let's make sure, do the paperwork and things necessary for her to get the biopsy in the hospital. So she got her biopsy, and it came back cancer. It came back breast cancer. I can't remember the exact type of breast cancer, to be very honest. It was some time ago. So it came back as breast cancer. So then she went ahead and she had a mastectomy, and she had chemotherapy, and she's fine. And it was caught early enough where she was fine. And so that was a big deal, because this mom, she's a mom, obviously she's a mom, she's a wife, and, it was just routine screening where this was caught, and it saved her life, basically. Maybe had this not happened, maybe it would have been caught at a later stage. Maybe it would have been more complicated. Maybe the prognosis wouldn't have been as good. And so that was to us a great example on how just trying to improve the care that you're, providing can make a big difference in the lives of not just a patient, but a whole family, So when we talk about quality measures, there are stories behind those measures. So that's what quality improvement means to me, kind of that story, basically. You just make an effort to improve the quality of what you're doing. Usually you have a measure tied to it. And the measure is like a proxy for, if we're doing better on this measure, then you can reasonably conclude that we're providing better care. And then when even if you don't meet the goal of the measure, you make some efforts to improve the quality of the care that you're making, and you can save somebody's life, basically. So, all right. So, and so that's what I like to tell people, is that behind the numbers, there are stories, there are faces, any little improvement, you may have saved somebody's life. Any little improvement maybe prevented somebody from going to the hospital, stuff like that. So, okay, guys. So, and actually, in a way, quality is why, personally, I think I went into medicine. I would say, I think that, the ability to make a difference for someone, essentially, that's what, that's that's one of the cores of what quality is, making a difference or effectiveness. So, all right, guys. So let's look at the first case here. Ready? Before we go into it, how was you guys this week? What'd you guys do last week?
Just study.
That's good. That's good. That's, just gotta hit the books. What can you remind us what test you're studying for?
I'm studying for my step 1 right now.
Oh,
so
okay, step 1.
Just doing some questions and stuff.
Yeah.
Besides that, it's been pretty hot here in Jersey.
Yeah. It's been more than 100 degrees? Or
Not more than 100, but it's been like in the mid-90s.
Oh wow. That's very hot. My goodness.
Yeah.
Yeah. What about you, Mohammed? What's the weather been like in Beirut?
Same here in Beirut. It's really hot, and what's a little more challenging is the humidity because we are just by the sea. I live in Beirut,
Yeah.
just by the sea, so it's hot and humid. And good luck, Khurram, in your exam. I'm
Thank you.
studying
Thank you,
as
brother.
well for the OET exam, which is also
Yes.
a requirement for ECFMG certification before I
Yes.
apply.
Yeah, because of Pathway 6 now.
Yes.
Yes.
Khurram, do you have to take that English exam?
Yes, they're making all the foreign graduates take that now. It's something called Pathway 6. If you don't qualify for other pathways, you have to go through Pathway 6, so which includes the OET exam, the English proficiency.
Actually, all pathways you have to do the OET. I'm going
Oh.
for Pathway 4, which is what my university recommended. And still, any pathway you have to do OET is just in the place of the clinical skill exam, step 2 CS.
Okay, all right.
Yeah.
Oh, okay, all right. That's interesting. But then, okay, so for Pathway 6, instead of the regular CS, I have to do a mini clinical skills assessment
Yes.
exam.
Yeah. It's called mini sex forms. You have to fill them up.
Yes.
Yeah.
Wow, I can see a lot of changes over the past several years.
Only last
Yes.
year. Yeah, only last
This-
year because of the pandemic.
Yes.
See. And Khurram, when is your exam?
Hopefully next month I will be
wow.
taking it.
Okay.
Yeah.
Okay. Well, good. Well, hopefully some of the material we'll cover today will at least help with that portion.
Absolutely.
Yeah.
If they do quality on step 1, I'm not sure if they do.
They're asking more I guess you can say more behavioral aspects of like what like maybe give you a little patient's background, what could have been done, what exam could have prevented, or stuff like that. So
Gotcha. Okay. Very good. Good. All right.
definitely more human aspect to the exam now. Yes.
Wonderful.
Yeah.
Okay.
Yeah.
Okay, wonderful. All right. Well, let's get started. So the first problem here. So I want to say this is common, this scenario. An official from one of the insurance companies you participate with sets up an appointment to discuss quality improvement measures you are thinking about implementing in your office. In preparation for the meeting, you review the literature on quality improvement. Okay. Actually, what's interesting is that this is actually very kind. I think usually I think the insurance companies, they have quality measures for you. So it's not necessarily quality measures that now the thing is, it's what insurance companies do is that, they've taken a very collaborative approach. Oftentimes they have a physician on their staff actually as their medical director to collaborate with your office. And, they'll sort of review for the patients that you both have, that you're taking care of and have that insurance. How are those patients doing on certain quality measures? So the insurance company will oftentimes sit down and review that and talk about opportunities for improvement. So, anyways, it's kind of funny. It's like, they're going to talk about measures that you're thinking about implementing in your office. I'm like, yeah, that too. But also they've got measures that they want you to do too.
Yeah.
Now, those measures actually we'll get to their categories. So number one, among the many, as the clinician, you're going to try and reference some resources to get, to be more prepared for a conversation on quality. So among the many possible internet sources for information about quality improvement you find, which of the following is most reliable? Is it A, the American Academy of Family Physicians, B, the Agency for Healthcare Research and Quality, C, the National Committee for Quality Assurance, D, all of the above, or E, none of the above? What would you guys say?
AAFP for sure. I like I like to use them. They now even recently fighting for value-based payments, and you can use them as a resource for quality improvement for sure.
Okay, good.
Maybe
had-
D.
yeah, I was gonna say maybe it's all of the above.
I would tend to agree. I would say all of the above. So let me see. Bear with me. I'm actually looking for some tissue here in the office. There is no tissue. Oh dear. Okay, might have to run and grab some. So, yeah, no tissue here. All right. So there are a lot of allergies here in the Kansas City area. So,
Oh man.
all right. So I would tend to agree. And the answer here is definitely D, all of the above. So, so basically, as far as the information here, so there are many sources of reliable information on quality improvement measures and interventions on the internet. Literally, you can Google this stuff. For the family physician, and that's kind of the lens that we're taking, is the family physician. By the way, I will say the family physician approach to a lot of these things lends itself well to your different exams, especially if you're talking about USMLE, clinical skills, and so forth, because family medicine encompasses all the subspecialties. So, you know, a lot of times when you study family medicine sources, it actually prepares you well for these different exams. So. Okay, so for the family physician, reliable sources include the AAFP, the AHRQ, and the NCQA, all right? So these are all very well established agencies when it comes to, quality. The AAFP, for example, contains links to practice management and clinical care and research information. The AHRQ website contains links to evidence-based practice reports, clinical practice guidelines, and information on preventive services. The NCQA website contains information on a variety of accepted quality measures, including the widely used HEDIS measures. So that's the NCQA. So all of these are great resources. I would actually add one more, to be honest. And that's the Institute for Healthcare Improvement. So the Institute for Healthcare Improvement, you can literally locate process improvement and quality improvement kits, where it equips you with tools and methodologies for implementing quality improvement in your office. So it is an excellent website. So the whole movement of quality really started to take form in the 1980s in the United States. And there are a lot of reasons for that. Actually, the very first effort when it came to improving quality, and it actually started off as safety, actually. And it started by, and I have to apologize, the name escapes me, but there was a surgeon with the American College of Surgeons, and he developed a sort of entity within the American College of Surgeons, I think, which was sort of like a committee on patient safety, and I forget the name, but that was actually the forerunner. It was sort of the initial version of JACO, and they don't call it JACO anymore, they call it the Joint Commission. I don't know if you guys have heard of the Joint Commission.
Yeah.
Good. So the Joint Commission is what certifies hospitals that they meet certain standards of really safety and quality. And it's not just hospitals, actually, but it's really all healthcare organizations. So before it was called the Joint Commission, it was called the JACO, the Joint Commission for Accreditations of Hospitals, the Joint Commission for the Accreditation of Healthcare Organizations. But it was decades ago. It was maybe almost a century ago. It started off with this surgeon as part of the American College of Surgeons. Anyway, that was the first hint of safety, of a movement to improve safety. Fast forward to like the 1980s, there was a lot of things that came up, and I'm not an expert on the history of this, but I'll just share what I know. The so there was sort of indicators that there were problems with safety in healthcare organizations, primarily hospitals. So, for example, there was data on for example, anesthesia complications. And what really spurs it is when there's media attention. When there is media attention, look out. There's going to be some changes, is my observation. There was one patient at the Dana-Farber Cancer Center, which is a Harvard University affiliated cancer center in Boston. And her husband was, I think, a researcher there, or an oncologist or something, or she was a researcher there, something like that. And she got an overdose of chemotherapy and died. Okay. So this was an incorrect dosage of the chemotherapy, and she died. So the Boston Globe, which is the major newspaper in Boston, published this, and there you go. It was a lot of media attention on how could something like this happen? How can something like this happen? You have someone who is, by all indicators, privileged. Either her or her husband was actually an employee of the most prestigious cancer institute, arguably in the world. She's a patient there, and she gets the wrong dose of a chemotherapy agent. So things like that, data on anesthesia complications. So there got to be, so these are some of the things that came together to sort of heighten the medical industry's awareness of the importance of safety. So then there was a pediatrician by the name of Don Berwick, who was, I think, like at the time, he's a Harvard University trained pediatrician, and he was interested in quality because part of his job was to review the performance of physicians of his medical group. And he consulted, so that was his job. He consulted with NASA engineers on some methods of quality. And then he became prominent in the field of healthcare quality. And then the National Institute of, or the National Academy of Medicine, it had another name at the time, they actually published a Sentinel article in 1998 called "To Err is Human." And that's I should have put a link on it on this slide. That paper sort of extrapolated how many deaths there are per year in the United States as a result of medical errors. Okay, medical errors is part of quality. And so it was almost like it extrapolated from available data to suggest that it's like 3 jumbo jets per day crash, and that's how many people die as a result of it. So, something like that. Don't quote me on that, but I believe it was in that neighborhood. So then that spurred the movement even more. And so ever since then, the momentum for improved quality in healthcare has been picking up. Don Berwick a co-founder of the Institute for Healthcare Improvement. Okay, and to me, this is like the preeminent resource for tools to implement quality improvement. NCQA, that is actually, we'll talk more about that, but you can look at their website for all the main quality measures, which again, we'll talk about. And not only that, but the NCQA is responsible for certification for something called the patient-centered medical home in the United States. And my organization has this NCQA accreditation. So those are just a few things about just a few items about these. And of course, the AAFP, nowadays, the AAFP, you can actually look up evidence-based guidelines on their website. And they have, the AAFP, they have a whole practice management division within the organization that you can get resources for process improvement. So yeah. Okay, guys.
Yeah.
Moving on. Okay. One of the products of the National Committee for Quality Assurance that you run across online is HEDIS. What are some of the, which of the following is true about HEDIS? What would you guys say? So what is HEDIS? We talked about standard quality measures across the country. That's what HEDIS is. HEDIS is that set of quality measures that insurance companies use. So when insurance companies sit down with you, they say, okay, doctor, let's see how your organization's quality measures are doing. It comes from HEDIS measures. And there's lots of them. So what would you say?
B.
B?
What's that, Horam?
Would it be B?
Okay, we have one vote for B. All right, Mohammed, what would you say?
Also B too.
B, okay, let's take a look here. HEDIS stands for Health Employer Data and Information Services. I don't believe that's the case. B certainly sounds good. Effectiveness and safety. That's what we've been talking about.
Mm-hmm.
C, HEDIS measures are not concerned about cost, just quality. I can see why you would be skeptical of that. D, HEDIS measures are designed to be primarily applicable to patients with Medicare insurance. That's not something we really stated, so probably wouldn't go for that. And HEDIS measures are updated every 5 years. I actually don't know. I'm not sure. So I would probably agree B sounds good. So let's see, what is the answer? Okay, the answer is B. Okay, does anybody want to guess what HEDIS does stand for?
I'm not sure.
It stands for Health, Effectiveness, Data, and Information Set. Yes, that's what it stands for. All right. So, so that's what HEDIS stands for, right? And actually, so here's a link right here. Let me see if I can click on it. Oh, it won't let me. That's weird. Let me see. Well, here's the link for all the HEDIS measures. Let me see if I can pull it up. I was hoping I could. Bear with me here. Share screen. And I want to pull up that website is what I would like to do. Desktop? No. No. Oh, that's weird. That is weird. Hold on one second. Yeah, I want to share that. I believe it's this. Okay. All right. CQA HEDIS. It's right here. So here are all the HEDIS measures. And this is where pretty much like what insurance companies will go from and other organizations as well. So you can see that the HEDIS measures, they're divided up into these categories: effectiveness of care, access, utilization, and measures reported using electronic data systems. So if you look at effectiveness of care, there are further subcategories: prevention and screening, So you see adult BMI, cervical cancer, colorectal cancer, different measures for respiratory conditions. So if you just click on high blood pressure, it talks about this measure in more detail. And not only that, but it shows you benchmarks. So these are the benchmarks for different, some select insurances or insurance categories, and what the benchmarks for that quality measure is. So controlling high blood pressure, as you can see in a commercial HMO, for commercial HMO plans, here is the benchmark. For Medicaid HMO, here is the benchmark. Looks like Medicare is still pending. But here are all the different benchmarks and all the different years for these insurance categories. So you can do this for each of those measures. So it's helpful because you have benchmarks to go with. Okay.
By the way, Dr. Murad, quick question. Speaking of high blood pressure, is the new guideline like your if it's even over like 120, that's pre-hypertension now?
I think so. When it comes to the, hang on one sec. Let me just get back to that. So yeah, so pre-hypertension has always been when you hit 120 over 80, and then you hit 140 over 90. That's hypertension. So then there's some caveats with that. One caveat is that if a patient has significant chronic kidney disease, or if they have diabetes with proteinuria. So chronic kidney disease or diabetes with proteinuria, potentially that blood pressure, that threshold for hypertension gets to be lower. Now, the other thing is that the JNC8, if I'm not mistaken, JNC8,
I think it is the 8.
yeah, talked about how 150 over 90 would be the threshold if a patient is 60 years or older. I don't believe that's widely endorsed. So, you know, I think in the absence of chronic kidney disease, you're safe if you stay with 140 over 90.
Oh, okay.
I hope I said that right. Yeah.
Yeah.
So, okay. So anyways, so yeah, and actually it's interesting because for that blood pressure measure, there's no 150 over 90 in that, okay? And there's no 130 over 80 in that measure either. By the way, for quality measures, a lot of times there's exclusion criteria. So if a patient is outside of a certain age, if they have certain comorbidities, a lot of times they may be excluded from that quality measure. So just so you know that is something that there's always a lot of attempt to take that into account. Okay. So yeah, so it's worthwhile browsing these measures on the NCQA website. Okay, good. All right, next. Examples of HEDIS measures, and we talked about what it stands for. By the way, a good thing to do when you're taking a test is to use the questions of the test to answer questions. So you use some questions to answer other questions. So if you look at number 3, it talks about examples of HEDIS effectiveness of care measures. So then you're like, okay, well, probably B that talks about effectiveness is probably a good answer, if you see what I mean. So if ever there's an opportunity to use a subsequent question to answer the question, a subsequent question to answer the question that you're on, take advantage of that opportunity. I don't think it happens on the boards that often, to be honest. I don't think so, but in other situations it may. Okay, moving on. So examples of HEDIS effectiveness of care measures applicable to family medicine outpatient practice include which of the following? Which of these HEDIS measures apply to family medicine?
All of them.
Yeah, it's a safe bet. What do you think, Khorram?
I believe so, yes. As a family medicine, you will see childhood and be doing immunization stuff. You'll be doing screening for cancer, for the flu vaccine. And for a second I forgot, but yeah, I guess you'll be seeing pregnant females as well. So you'll be trying to do effective care in all of these.
Exactly. So I would agree. The answer is, by the way, that's one thing about quality improvement is that a lot of it is intuitive too. Okay, a lot of it is intuitive. As long as you're not scared of numbers. If you're scared of numbers and measures, then yeah, quality improvement can be rough. But if you're not scared of numbers, a lot of it is intuitive. So, okay, let's take a look. So examples of effectiveness of care measures in HEDIS include measures of childhood immunization, colorectal cancer screening, measures of influenza vaccination rates, and measures of frequency of prenatal visits. So yes, I mean, that's pretty straightforward. And then go to the website for the complete listing. Let me actually bring up something else, which we actually brought up last time. If you guys remember, we talked about like quality measures at our organization, right?
Yeah.
Well, let's take another look at it, actually. So if we go back here, HEDIS stands for this. It stands for Healthcare, Health Effectiveness Data and Information Set. So we work in a community health center. A community health center, we have measures that apply to us. Where do they come from?
HEDIS.
They come from HEDIS. In fact, the measures that apply to community health centers that come from HEDIS, it's called the Uniform Data Set, or UDS. That's what they're called. So for us, it's so it comes from HEDIS, but it's called UDS. So now, if we look at, let's take another look at those measures and see. Oh boy. Share screen. Let me see. Boy, it's amazing how much time I waste just trying to share. Okay, so, okay, here we go. Let's log in. Oh dear. Hold on. So here's our organization, and here are our UDS measures. So let's take a look. We talked about immunization, right? So do we have immunization? Yes, we do. Childhood immunization. What else did we talk about? We talked about colorectal cancer. I think we looked at that even in detail last time. Do we have colorectal cancer? Yes, we do. In fact, these are codes. They, you know, I think those are, actually, I don't know what they are. I think they're like the HEDIS codes for these measures, but colorectal cancer. What was another one that we talked about? Actually, influenza and prenatal care. Actually, it's not on here, but you know, if we go, if we can actually get more details on a bunch of other measures. So these are our what we call UDS measures, but we can even look at a whole bunch of other measures here. And they're all these categories as well. So we even have the ability to look at other
childhood.
Yeah, so there's HEDIS childhood immunizations. And so you can see there's a HEDIS measure for actually each one of these categories within childhood immunizations.
Mm-hmm. How is your MMR vaccination rate?
That's a good question. How is our MMR? Let's take a look. Pretty good, huh?
Yeah.
So yeah. So we can see, and I know that our organization, we have an excellent vaccine manager. She is an excellent. She's excellent at what she does. So our staff, they do a great job in terms of getting those immunizations to, you know, to all the kids who need it. So yeah, and if we look here. Actually, we compare ourselves to other centers. Actually, compared with this one, only this center has more patients than us, actually. Yeah, so we have the second most patients, and we are 4th place, basically. We're in 4th place. We have a little bit, I mean, they only had 11 patients, so that's pretty easy to get, but we're not far behind these guys. So yeah. so now we know where these measures come from. They come from the HEDIS measures. So, any questions? All right, let's move on. Okay. So, improving practice quality. So after reviewing the literature and reflecting on what you have found, okay, so remember, we're prepping for this meeting with the insurance company, you decide that good physicians should actively learn from their practices. This means taking the time to reflect on your patient's care practices, to assimilate new and existing scientific evidence into the care of your patients, and always seeking to improve patient care. Something that I'll mention, one of the things about quality improvement, which I guess on one hand can be daunting, but on another hand can be reassuring, is that you're never done with quality, never done. And so even if you think you've improved a lot, you still need to continue improving. So on the one hand, it's like, oh my goodness, we're just always, we'll never get there to where we are done with quality. But on the other hand, it's not a bad position to be, because your goal for quality is just improving. As long as you're improving and moving the needle, that's the most important thing. Maybe you get to the goal, maybe you don't. Maybe you get the goal, but much later. But as long as you're always improving, that's what counts. So that's the part that I personally enjoy. And there's a lot of opportunity for creativity. So when you're working, like those measures we were looking at, right? When you're always working to improve them, anybody's idea could be good. So there's opportunity for creativity as well. So anyway, that's another reason why I personally enjoy quality in a family medicine setting. So let's go to the next question. Why don't you guys take a look at this question? I'm going to go find some tissue, okay? I'll be right back.
Probably all of the above.
Yeah. Yeah. It's the PDSA technique. You learn it for step 1, I think. You plan, you do, you study, and then you act, right?
Yeah.
So this cycle, how to you collect data, analyze it, try it out if it worked, and then
if it works,
integrate it.
Otherwise just start over.
Yeah.
Mohammed, you're already licensed in your country?
I am not. No.
Oh no, but you have already graduated.
Yeah, I studied in Poland, not here in Poland. I'm just here to visit family, and since I couldn't come to the US, so I'm doing this online. Yeah.
So you studied in Poland. You're licensed in Poland?
Last year, you said?
No, you're licensed in Poland, or that's just where you graduate?
I can practice. There's one test I have to take, but I didn't take it because I'm not planning to work there.
Oh, okay.
Yeah. You finished your med school, right?
I have just one more elective after this.
Okay. So in terms of years, you are done, like courses.
Yeah. I'm
done.
I'm essentially done. Yes.
Yeah. Same.
Just Pathway 6 is made it a little hassle.
Yeah. I already done my electives, but I asked them not to put it on my diploma. So I will do some US electives and then I will add them.
That's good. Yeah. Have you done any before?
No, this is my first US elective.
Try to do like maybe 3 or at least 2.
Yeah, I'm actually planning to do 3. Hopefully.
Do you know what you're doing next?
I'm doing all of them family medicine. I'm planning to apply to family medicine.
Okay.
So
all right. Yeah. I start radiology on Monday.
Oh, this coming Monday. Nice.
Yeah.
Interesting. Good luck in that.
Thanks.
All right, gentlemen. What'd you decide?
Everything.
Everything? All right, let's take a
E.
look. E.
It makes the most sense, I believe.
Okay, let's see. Let me see. Systematic collection and analysis. Sounds good. Sounds good. Sounds good. Okay,
Yep.
let's see. The answer is, yep, answer is E. So, okay, so that's pretty much it. Let's see if there's any additional information here. So basically all of these methods have been shown to improve improve quality in a primary care practice. So let's see if there's anything new here. Yeah. I mean, so I definitely agree. I think one of the biggest, I think when it comes to a successful, I guess, successfully moving the needle, engaging the staff is very critical, because staff, so you have staff they're the frontline folks, and
Yes.
you know, without engagement, there's a lot of things that you're supposed to do that a lot of times you're just not going to if you don't think it's important. And especially in healthcare, because healthcare is very time constrained. It's very time constrained. There are so many things competing for our attention and what needs to be done.
Yeah.
So if you need the physicians to document something in the chart, right? If they need to document something in the chart that will be helpful for quality, well, they may do it, they may not. Just because you ask them to do it doesn't mean they're going to do it. Why is that? Because they are focused on getting through clinic. They just need to get through clinic, okay? They need to finish their notes, get their stuff done, and get out. That's what they're focused on. So if they're going to do it, they need to be properly engaged in what this overall effort is. So that's just very, very important.
It's called safety culture when it's called safety culture when everyone has the right to express themselves easily, no matter what level they are on. Although there's no actual levels, but just what their responsibility is.
Right. In fact, let me share something that I bring up during our morning huddle. When we huddle in the morning, I'll share with you something that I bring up. Hang on one sec. If you do new share, oh, okay. You could do new share. That's a good idea. Okay. Let me see if I can find it. Hold on a sec. There it is. Okay. This is a sample of what I discussed during morning huddle, actually. As you can imagine, morning huddle, a lot of times we do it on Zoom. And so I share things during the morning. The whole organization comes together. This is essentially like a safety huddle. This is to your point, Mohammed. So we all get together in the morning and we discuss things, okay? We discuss things. In fact, I have my little agenda here. On Wednesday, I call it Quality Wednesdays, where we talk about certain quality measures. In fact, if I go back far enough, here's an example of Quality Wednesday, actually. This is the breast cancer screening rates of all of our physicians or providers, as nurse practitioners as well. So we go through a little game on who has the highest breast cancer screening, who has the lowest. And we review it publicly, actually. And, you know, and I actually don't have the names here, and we guess. So we kind of do that as a fun little game. And then we use it to emphasize, okay, guys, let's talk about what we need to do for breast cancer screening, okay? So, so this is an example of how we review quality measures in the morning and provide feedback to the providers on the quality measures. So this is during our huddle time in the morning. But more to your point, Mohammed, it's this thing right here. This is actually a communication tool to express a safety concern by, again, to your point, anybody there. It doesn't matter who you are. Maybe you're the medical assistant, maybe you're the doctor, maybe you're the CEO, maybe anybody, okay? And this is a tool for how to communicate a safety issue. And it starts off by saying, and this is what we share with people. You start off by saying, I am concerned. When someone says, I am concerned, that makes us listen and say, oh, there's a potential safety issue here that we have to address. If that safety issue is not addressed, then the person says, I am uncomfortable. So this is like, hey, listen, I'm very worried about this, and I don't know if anything has been, I think it's still a problem. And if still things are unresolved, then again, doesn't matter who it is, they can say, I believe this is a safety issue. When someone says this is a safety issue, then they are ringing alarm bells. They are setting off an alarm saying if something imminently dangerous is about to happen. And if nothing is addressed, I'm going to have to escalate to a higher level to address this issue. So this is a tool that we say cuss. You want to cuss. Of course, Mohammed, I don't know if, sort of the nuance to here. So the nuance to some of the English language stuff. So cuss is like cursing, cursing, say bad word.
Okay. Yeah.
So cuss is a variation on that. It's a variation to cuss. So it's like, we want you, so we tell people we want you to cuss, okay? Which is, we want you to use this tool. Now this tool, you may wonder, okay, that's cute. Where did this tool come from? This tool actually came from, the AHRQ is where that tool actually came from. So that's where we got it from. And so again, these organizations are good resources for you as you look to improve safety. So for us, because we were having an issue with people not communicating appropriately when it comes to safety. So communication was often not in the best way, not the appropriate manner, or, and also it wasn't clear. I mean, sometimes there was a hesitation for people to report safety issues. So we use that tool to say, oh no, listen, this is a tool for anyone to use. So that's to your point, and that's how we apply it in a family medicine setting. So,
Dr. Matz, so like our topic today is quality improvement and everything.
Right.
Like, what do you think is one of the reasons that like the third most common death in the U.S. is still medical related, like the medical errors related?
Yeah, that came from that paper that we talked about. To err is human. In fact, if I were smart, I would have gotten a logo for that. I would have put an image on that on the slides. But that's where it came from. It came from that paper, and actually, to err is human. And then actually the title is longer than that, but that's how it starts off. And so yeah, I mean, I think that's why this issue is so important. Now, I think that what's interesting is that we actually want more safety incidents reported, because the more safety issues that are reported, that indicates a better safety culture. So I think when you look at, I think to your point, Horam, I guess my perspective is that healthcare is complex. It's not simple. It's not even complicated. It's complex. So that means that there are a lot of factors that are interdependent on each other. So because we work in a complex environment, oftentimes things are not, it's not, a lot of things can, there are a lot of opportunities for mistakes and errors to happen. And
I mean, I think one of the improvements that they actually made was, I think it was a resident in New York back in the 90s that worked a 24-hour shift and still had to come the next day. And he accidentally did something that caused the patient to die. And that's when they introduced, like, if you were working a 24-hour shift, the next day you had to be off.
That's another
stuff like that.
Right. That's okay. So this is the introduction to work hour restrictions. I think this is the Libby. I think it's the Libby Zion case. Let me double check that. Libby, is it the Libby Zion case? Yeah, Libby Zion law. Yeah, this is the Libby Zion case. So this is in this case a patient. What happened to her? Oh, what happened to her? I can't remember exactly, but she died, and her dad was a journalist. And I think her dad was a journalist for a very prominent newspaper. Maybe it was the New York Times, actually. Oh, who was it? Okay. We can come back and look at the details. But yes. So her dad was a journalist, and he kind of course, this is a tragic event. He looked into it, right? And he said that, oh my goodness, look at these work hours that they have, right? Look at these work hours. This is this is unacceptable. And so that's what prompted the first round of work hour restrictions for residents. Since that time, there have been other rounds of work hour restrictions. And I don't know, after the first round of work hour restrictions, let me tell you, the current version is very different than when I was in residency. This came a few years before I started residency. And basically, for me, I could work a 30-hour shift, but I couldn't work more than 80 hours a week. And to be honest, I think that was it. That was it. I mean, I think that was the extent of it. Now it's different, actually. Now it was 30 hours, but I couldn't work more than 24 hours of taking admissions. But I can stay 6 more hours of like rounding and wrapping up care. So this is, to me, Horam, this is an example of when media attention comes to a topic, how it is very powerful in implementing change. Because this story happened, and like it just felt like very soon afterwards you have these work hour restrictions, and it was because of media attention.
And I was reading some stuff, I don't remember where, but like, you know, some people say, oh wait, residents are not working the ridiculous hours, or they're learning as much or whatever. And I did said, yes, they're learning. The quality of physician being trained has not declined due to these work hour restrictions.
Yeah, I don't know. So regarding evidence for if it improved safety, I'm not sure there is. So starting with that outcome, like, okay, did work hour restrictions, did that improve safety at all? I personally think it's not so much.
Maybe not a statistical significance.
Right.
I mean, it definitely helped individualize, but I think there was not, I don't think there might not be a statistical significance though.
Yeah, I mean, it helped with work-life balance, I'll tell you that.
Yeah.
But I believe personally there are other factors that go into it. I think another important factor is supervision. Okay, I think supervision is a very important factor. And if you ask me personally, my anecdotal sort of experience is that it's more important than how tired the resident is, to be honest. Anyway.
If you're not being supervised properly, then whether you're tired or not tired.
Yeah. So I think, anyway, I think, did it improve patient safety? I think that's questionable. What was the other outcome, Horam, you mentioned? It was...
Well, I mean, that once the residents finished their residency program, it's not that they were not as...
Yeah.
I mean, I think there might have been... That's what most say, I think, like...
Yeah. I think when it comes to residency, I think the name of the game is experience. That's the name of the game.
Yeah.
I think that what happens in residency is that you are just trying to catch everything You're trying to catch all the experience you can get before you start practicing. So I question, and look, I'm faculty. I work with residents all the time. And, I can see residents struggling to get certain procedures,
Yes.
They can't, there's some procedures like an IUD insertion. I mean, if a resident gets 5 IUD insertions in 3 years, that's a miracle, and then when they come out of practice, they're expected to do it. Now, I think there's some of that in all residency programs. So for example, an OB-GYN resident that just gets started, they'll have someone help them out with some laparoscopic procedures for a while, for a little bit. Stuff like that is normal. So it's okay, but I do think the name of the game is hours of experience. I do feel that. But okay, fine. That's just an impression I have. Do the work hour restrictions actually make a measurable difference? I don't know. So, but anyways, so this is more, I feel like it is a safety issue. It may be more of a medical education topic, to be honest, but it is an important safety. Clearly it is a safety topic in the sense that it is an example of how media attention came to an issue and it resulted in significant change. So, good. Okay. I think, any other questions? No? Okay. All right. So so the morning huddle is an example of how we give feedback to our providers, to the points of these other choices here. So, okay, next. Which of the following is or are essential elements of a high-performing family medicine practices? What would you guys say?
I definitely think B is a correct answer. I'm just deciding if A is also will make a difference. The electronic patient.
Sure.
Clinical information system. Is the electronic patient clinical information system, or is it just referring to like what you have at your organization, doctor?
I think they're probably talking about EHR.
EHR. Okay. I'm talking about electronic.
So D maybe.
So maybe D.
Let's see. Let me see. Let me go through it too. So you guys picked D, huh? Let me see. An electronic patient clinical information system, open and direct communication among all members of the practice, a leader who tolerates little deviance of accepted thought from employees. A and B or A and C? Well, I think, I would be very skeptical of C. That just doesn't, a leader who tolerates very little, that just doesn't sound like that can, I don't know how that can be good. So, I would go with A and B. So let's check the answer. The answer is, oh my, the answer is B, you guys.
Doctor, I just remembered from lecture 1 in which they said an EHR does not make much of a difference. Or I think we had a question like that.
Right. Wow. Okay. Well, it's good we did this. So, let's look at the answer, shall we? Yeah, I would have picked D. Okay, so but let's learn from this. Okay, so a large body of literature. So B. Yeah, that's it. So a large body of literature supports the finding that primary care practices are not just small businesses, but complex organizations. And that's something else that we would emphasize. Even if let's say you have a small practice, it's still a complex organization. Anything healthcare like this where you're delivering patient care, by definition, is complex. And there are levels. There's simple, there's complicated, and there's complex. So complex means that the outcomes are not easily predictable. I mean, it's almost like, that's why quality improvement is sort of like being a scientist. You have a hypothesis and you have experiments, and then you do measurements after the experiment to see if your hypothesis holds. It's very much a scientific method, actually. So in that, just like biology is complex, healthcare is the same. So anyways, sorry, go ahead.
Oh, sorry.
Yes.
My allergies too. I was just clearing.
Yeah. I had to look all over the place for some tissues. Okay, so anyway, so the point is that even if it's a small practice, it's still a complex organization. In addition, studies have demonstrated that the quality of work relationships among members of the practice is important for the successful functioning and delivery of patient care. Okay, so I guess that's talking about, that's talking about B and C, really. Yeah, let me tell you guys something. Perhaps we talked about this before. If a culture is toxic, it is bad for quality and bad for safety. Okay, very, very bad. So you need to have good, constructive relationships. Now, characteristics of work relationships associated with successful practices include high level of trust, i.e., you trust the other person to kind of have your back when it comes to taking care of patients, and you're not worried about being harmed in some way. Some places can be quite toxic. The presence of respectful, mindful, and heedful interaction. I think that when you're interacting in a healthcare type setting, if communication is constantly bad, where things are not being communicated well despite good efforts, something is wrong, okay? Something is very wrong. Communication needs to be relatively easy. If it is so difficult to communicate, either verbally or written or in some other fashion, if it's difficult to communicate, then something is very wrong with those relationships for whatever reason. Like, it should be easy. Like, if we're talking, it should be pretty easy. You understand me, I understand you, more or less. We get it. We give grace to each other if things aren't perfect, but it's pretty easy. Being pretty easygoing with communication, that's important.
Especially if it's related to safety, then there should be no constraint put onto any person. He or she should say straight away that something is going wrong. Especially.
Yes. You should be able, exactly. You should be able to, this is the open communication part. You should be able to approach someone and say, and you can be respectful about it. By the way, let me share an experience I have. So direct communication. There are 4 communication styles, okay? There is, let's see if I can remember them. There's direct, there is aggressive, there is passive, and there's passive aggressive, okay? So aggressive is when I'm like yelling, okay? That's aggressive, okay? Or I'm insulting, okay? That's aggressive. Direct, you're saying the same thing, okay? But instead of yelling, you're just saying it in a more respectful, calm way. You're actually saying the same thing, okay? But it's how you're saying it. So that's direct. So instead of saying like, I can't believe you did this, this is like, yelling, you'd say, well, I think this happened. Perhaps maybe next time we could do it like this, okay? Then there's passive, where, let me tell you, so passive is where you just do nothing. Something is wrong and you're like, oh, well, what can you do? Passive is kind of lack of communication, actually. Passive aggressive is when you complain about something, but you're complaining to the inappropriate person. So let's say, Khurram, let's say I promised Khurram I would do something, okay? I promised Khurram I would do something, and I didn't do it. Like, like sending the links. so, so sorry guys. So let's say I told Khurram I would do something and I didn't do it. So Khurram would then go to Muhammad and say, this guy, what is this guy doing? This is ridiculous. How many times? I'm sorry, you guys. What happens is right after we get done, I start volunteering at the Medina Clinic and doing patient care. So then I get tied up. But today actually is the July 4th weekend. So we actually don't have clinic at the Medina Clinic. So I can do it. I can do it right after.
No patients today, doctor?
Was that?
No patients today?
No, not today. Yeah, we're not volunteering today. So it's off. So today can do it. So.
Doctor, who runs who opened Medina Clinic, or who started it?
Yeah, I mean, I can tell you. Basically, the Medina Clinic, it's a charitable clinic, and I co-founded it with my wife in 2009. And basically, when I was in training, like in residency and in fellowship, I volunteered in free clinics all the time. And I loved it so much. So, and that's kind of why I went into medicine. You want to try and help people, try and, make a difference, do good deeds, things like that. So then basically, I got out of training and I promised myself that I would start a charitable clinic, okay, after I got out of training. Or that's what I recall anyway. And so then, I got married. I moved to Kansas City. My wife is from Kansas City. And let's see, basically, and then she kind of helped me, and we made it a not-for-profit organization. And of course, when you're a physician, like I mentioned, as a physician, you really don't get training in healthcare administration or quality or things like that. You get training on the medicine, but not so much the other stuff. So for me, it was actually kind of fun to try to start an office, because it was an opportunity to learn. And then basically my wife helped me out. We put our own money into it to get it started. And then probably after about 2 years, it became financially self-sufficient. So now it's financially self-sufficient. I don't have to put in money into it anymore. And it's operating with volunteers and, seeing patients. So this is how I volunteer on the weekends. And I love it. I very much enjoy it. And I hope you guys, when you guys practice, you guys become big shot physicians and you practice, I hope you volunteer as well. So.
Yes, yeah. Definitely, yes.
Yeah. Oh, and of course, over the years, we've had a lot of people come through who are looking to apply to residency, and then they get experience at our office, and then they apply to residency. So we've had a lot of that. In fact, Khurram, I'll tell you especially, in Missouri, there's something called the assistant physician law. And this is where medical school graduates can become licensed as mid-level providers. So if you've graduated medical school, and you've taken all your board exams, you can get licensed as an assistant physician. And as an assistant physician, you can practice under supervision. So nowadays at the Medina Clinic, we take advantage of this to help bring in volunteers at the Medina Clinic to see patients. So then it's not so much me seeing patients like it used to be. I staff the assistant physicians. The assistant physicians see the patients when they come in and discuss it with me. And it's just like residency. That's exactly what residency is like. You see a patient and you staff it with the attending. It's the same thing. So we use the assistant physician law to model a residency where they come, they volunteer, so that helps the office, but also they get experience to go into residency. So that's what we've done in recent years. So, yeah.
Nice.
Okay, yeah. So going back to our communication styles, so passive aggressive is where Khurram, let's say, talks to Muhammad and says, what is this guy? He says he sends the link, doesn't send the link. What's wrong with him? my God, like, this is ridiculous. He needs to send the link. He said he needs to send it. So what is he doing? He is being, sorry, Khurram.
You're complaining to the wrong person who can't change anything.
Exactly.
Yes.
So for Muhammad may say, well, Khurram, I agree with you, but maybe you should tell that to Dr. Murad. I mean, there's not much I can do, you know?
Yeah.
So then that's passive aggressive. Direct is where you say, hey, listen, Dr. Murad, and then this is where you use tact and you be respectful and all that.
Yes.
So you say, hey, Dr. Murad, I know you're so busy. Where, you know, you give people the benefit of the doubt. I know you're so busy, but I really would love that way ahead of time so that I cannot be late. I don't want to be late, right? So then that's being direct, okay?
Mm-hmm.
Aggressive is where we say, Dr. Murad, how many times is this going to happen? This is really causing a lot of problems for me. And really, I really don't like your lectures anyway. So I really don't know. I really don't know if I should do this. That's aggressive. Okay. So you kind of get the distinctions.
Yes.
In healthcare, what you want is you want direct. And my experience is that sometimes staff, different levels of staff, they misinterpret what direct means. Sometimes people will take pride in saying, well, I'm direct, and then they use that as a license to insult people. So yeah. It's like, no, that's not direct, that's aggressive. By the way, you're passive aggressive too, but we won't talk about that. Let's talk about this is what direct means. What you are saying when you say that's just me, that's how it is, I'm just direct. It's like no. You're aggressive, okay? So what you want to do is you want to say the same thing, but you want to be respectful about it. If you don't know how to be respectful, then that's another problem, actually. So anyway, so this is direct, okay, guys? So now you know these 4 communication styles. It is direct, aggressive, passive, and passive aggressive, okay? All right. Let's see if we can get through this answer here. So, okay, we said high levels of trust, the presence of respectful, mindful, and heedful interaction, okay? That's very important. These are soft skills, by the way, that will take you far. I just want you to know, these skills will take you far. They're soft skills, but sometimes people, they abuse the system in such a way where they feel like they don't have to do this stuff. But that we won't go off too much on a tangent. Now, here's the other point. The other point is a tolerance of diversity of ideas, a mix of rich, face-to-face, and lean, where by email or memo. So face-to-face communication is face-to-face. Lean is not face-to-face, but something written or a voicemail or a text message or something like that. So good communication usually involves a mixture of all of these things. So there's Zoom when we do our huddles, there's in person, there's email. You know, it's important to try and use a mixture of these methods for optimal communication. And the presence of both social and task-oriented interactions. I mean, this is all culture stuff. So interactions, they're task-oriented, but social. So what's an example? Okay, the huddles in the morning, that's task-oriented. We're talking about, okay, what's going on for the day? What's the latest news? Here are our quality measures. When it comes to safety, please communicate like this, okay? You know, that's, you know, we're interacting for work. And then it just so happens this week, my organization has a big social function where we're going to go to some fun place and have fun, I guess. So anyway, I'll find out where that is. But anyway, but that's good. I mean, that's important. And that's my CEO, what she decided to do. So you see, this is a social function, and we have task-oriented function. It's important to have both, okay? So, okay, now here's the thing about the EHR. Although, I gotta say, this is, let me just say that in like, really, anytime you see that someone doesn't have an EHR, you're like, oh, They don't have an EHR. Oh, wow. You know, like it's never this great thing. But let's see what the evidence is. Although electronic information systems can be useful to practices in the care of patients, they are not essential. What is essential is a well-organized team with common goals that puts the patient first. Okay? That's what's important. Any questions on that? I mean, I guess to me that makes sense because let's say you have a small practice and they're all paper. Well, if they have the best quality measures, who cares? You know, who cares? If you have the best outcomes, that's all that matters, you know? So that it just goes to show that the EHR is really a tool and you want to use the tool as best as you can, but it's not the end all be all in and of itself, so. Okay, well that was good. And you can see how important culture is as well. All right. Last case. So measuring quality. You decide to implement performance measures in your practice based on evidence of effectiveness targeting several major diseases in our patient population. In this process, you rely on performance measures for ambulatory care derived from the National Quality Forum. Okay. This is another organization that kind of came up from all these quality efforts in the past few decades. Okay, number 6. Which of the following is or are a reasonable performance measure for your practice to assess preventive care delivery? What would you say?
E.
E? Okay, Horam, what do you say?
Oh. I do believe A and C are correct answers. I'm just reading over B again.
Right. Yeah,
Yeah.
B, you can really look at it kind of critically, actually. I see what you're saying.
Yeah. So it says the percentage of women between the age at onset of sexual activity
Right.
and 65 years. So we're looking at who've had one or more Pap tests in the past 2 years. But you don't have a Pap smear until you're 21, right? So
Right. Yeah.
I guess D.
So I think you're both right. I think it looks like here the answer is E. But if I were a teacher grading this, I would give you credit, Horam, because you're right. Okay. You're right. This is actually outdated. And basically you're correct. It's starting from the age of 21. But you know, this brings up an important point. Where do these come from? Where do these different measures, the specifics on age 50 for fecal occult and 21, starting at 21 for Pap smears, like where does this all come from?
I guess.
Are you asking us?
Yes.
Okay.
It's from it's called USF. Let me Google it.
Yeah, you got it. You got it, Mohammed.
Task Force.
Yes, you're exactly right. So
each year it's updated, yeah.
Yeah, so this is where these measures are evidence-based. So let me see if I can share. So they're evidence-based. By the way, here's a Wikipedia page on the Libby Zion law. Hold on.
Yes.
So yes, the United States Preventive Service Task Force, USPSTF. And as you can see from my search history here, look at the stuff I look for. Cervical cancer screening. Hold on, there you go. I was just looking at it the other day.
Oh, okay.
Yeah, so you can go here, you can Google it, and you can bring up the guidelines. So you can see
So,
here that the USPSTF recommends cervical cancer screening every 3 years, starting from the age of 21. And then you can read on and on. But
yeah, and
yes,
then it says against screening women younger than 21.
correct,
Yeah,
correct. No,
yeah.
you
So
don't,
that's why I was not sure of B. That's why.
right, exactly,
Yeah.
exactly. So no, if I was a teacher, you would both get it right. So,
Okay.
so yeah. So you can see that the measures, oftentimes they come from this. And even if you go to colon cancer screening, you go to colon cancer. So let's do that. Actually, that was just revised, actually. Here's colon cancer.
Okay.
Check this out.
45, right?
45, yeah, but it's 45 is level evidence B.
Oh, so okay, that was B. Okay.
Yeah. So yeah, 45, yes, but you see, but and this is of course recent, but you see how when they say start for men and women starting at age 50, well, here it is. You know, here's where the metric comes from. So you can see how that this is a source for a lot of these measures. In fact, let me go back to that one platform for my organization.
And doctor, this task force, they do like, I guess, some type of retrospective studies, and then, or like, do they come out with these guidelines? Or
they don't perform the studies, but what they do is they review all the available evidence.
Okay, they review studies. Okay.
Yeah, they review all the available evidence. In fact, I remember when I was doing my master's in healthcare management, one of my professors, my epidemiology professor, he was actually like, he served on the task force for the different regarding some different recommendations. So now here is our quality platform. So if we go to it, what we see, let's go to cervical cancer. So then you're like, okay, well, that cervical cancer measure, does it abide by USPSTF? Well, we can click here, and here's all the criteria. Here's all the criteria. So here's the criteria for our quality measure, and we see that that it closely mirrors the USPSTF. By the way, you can see the steward of this measure is the NCQA. So this is our quality platform that we use. So we see regarding the measure, they enunciate the numerator, they enunciate the denominator, and they include who is excluded. If we look at cervical cancer, well, exclusions include those with a hysterectomy. If they had a hysterectomy, they're not going to get a pap smear, right? Well, not always. Sometimes they do. But you can see also that if they're in hospice, so if they're receiving terminal, if they're receiving hospice care at the end of life, that is also a reason why you're not going to do a pap smear on this patient. So these are exclusions.
And what does denominator mean?
So when we look at the measure, right? The measure is what? 70. Oh, dude, hold on a second. This is good. I need to report on these quality measures in the next few weeks, so I'm very interested in this. I need to make sure we're doing well. We dipped a little bit. 72%. Oh, man. Shucks. We're number 2 in our network. Well, that's good. Oh, well, okay. Anyways, so 72%. So the numerator, well, actually, the numerator and denominator are right here. Hold on.
Oh, that's your
Yeah. Out of 165 eligible patients, meaning those in between the ages of 21 and 64 who have a cervix, are not in hospice, right? So out of 165 of those patients, 119 are up to date on their pap smear, and that's the 72%. So going back to this here, the numerator and denominator, remember it mirrors closely the USPSTF guidelines. Yes. So the guidelines say, okay, in these patients and women 21 to 64, you need to have had a pap smear within this many years. that's where the numerator and denominator come from. The numerator is all the patients who qualify based on that recommendation. So all the women who qualify, and then, oh wait, did I say that right? I'm sorry, the denominator.
Denominator, right?
Oh my goodness.
Yeah.
Thank you for catching that. The denominator is all the women, or all the patients, in this case, the women who qualify.
Fine.
Obviously, men are not going to qualify, right? So all the patients who qualify are in the denominator. All the patients who meet the criteria for that recommendation are in the numerator. And so you want the numerator to be as high as possible so that you're as close to 100% as possible. Here, we see that we are 70%. We are the second best in our network. We are the second best in our network when it comes to this. So yeah. So this is an example on how our quality measures, mirror the USPSTF basically. So. All right, any questions on that? Let me kind of go back here. Okay. Okay, good. Let's move on. Okay. Which of the following is not a reasonable performance measure for your practice to assess care of patients with coronary artery disease or heart failure? What would you guys say?
Which of the following is not a reasonable performance?
While you guys do that, I want to look at my personal cervical cancer screening.
Okay.
I want to look at that. Oh my goodness. No. I need to share. You need to see the answers. I'm so sorry. I am so sorry. Here we go. I'm so sorry. Okay.
Maybe E, I think. I don't know. Maybe E.
Quorum, what do you think?
So the question is asking like which one is not a good performance to see how good you are assessing care of patients with either heart disease or heart failure. So is that what's patients? Is it D?
D. Okay, D. And what did you say, Mohammed?
E.
E. Okay. Let me take a look here. Let me see what I think. Percentage of patients with CAD who were prescribed. And you know what? I may just apply the experience from my organization to this. I'll see what my organization is doing. Hopefully, that's close to correct. So, okay. Percentage of patients who were prescribed a lipid-lowering agent. Now remember, they're asking which is not a reasonable, okay? So most of these will be reasonable, one of them will not. Percentage of patients with heart failure and left ventricular systolic dysfunction who were prescribed an ACE or an ARB, okay? Percentage of patients with 3 or more risk factors and without contraindications who are taking aspirin. So pretty much A is talking about, are they on a statin? B is like, are they on an ACE or ARB? C is, are they on aspirin? They're all kind of the same.
Similar.
D, percentage of patients with AFib who are receiving anticoagulation therapy, okay? And then E, percentage of patients with CAD who had an exercise stress test in the past year. Interesting. So E is suspicious for me for a couple reasons. One is that, okay, exercise stress test, not every patient can do an exercise stress test. There are lots of stress tests. Why does it have to be exercise, you know? So E is suspicious to me for that reason.
And past year, they said
Yeah.
you don't feel, you
yes.
keep on doing it also.
Say that again, Mohammed. I'm sorry.
The exercise stress test can be used with certain patients to help diagnose, but it's not done as a follow-up. They keep on doing it past years or yearly. I don't think so.
Exactly. And Mohammed, your point is the more important point. Yes, that's because what guidelines on this planet say that coronary artery disease, you need a stress test every year? No, like nobody recommends that.
Mhm.
So that's exactly right. AFib, because AFib, I mean, are you supposed to be on anticoagulation if you have
Yeah.
AFib? Vast majority, absolutely. A, B, and C, should you be on those meds? Sure,
Yes.
you know. So correct. E is not evidence-based. E is not evidence-based. So I would go with E. Okay, great. Let's see what the answer is. Answer is E. And it says that exercise stress testing is not recommended on an annual basis for all patients with CAD. Maybe some, but all other measures are reasonable and built on evidence-based guidelines. So that's the issue there.
Okay.
So this goes into what makes a reasonable performance measure. The performance measure should be based on evidence-based guidelines. So, all right. Excellent. So at my organization, there's lipid lowering, ACE, aspirin. If I may, let me just show you real quick.
I think you at your organization, doctor, you had a for statins.
Yeah.
Yes,
right?
I think I saw that.
Yeah. So if we go back to it real quick. So here's actually the home page. So if we take a look here. So here's aspirin. Okay. There's aspirin for us right here. As you can see, we're 96.7%.
Yeah.
Let's see. Statin. Where's statin?
Right. Statin therapy.
Oh my gosh,
prevention
it's right
and treatment.
there.
Yes.
Yeah. So statin is right there. So as you can see, we're at 91.2%. So yeah, we don't have one for ACE or ARB, although it makes me wonder if we went to other. So
maybe in hypertension. No.
Yeah. I mean, here's some hypertension HEDIS guidelines right here, or measures. By the way, we have meaningful use. That's a whole nother category. Patient-centered medical home. That's a whole nother category. Yeah, not quite seeing for an ACE. I don't remember seeing one, but I'm sure if we went to the HEDIS measures, we would find it. It's just not a measure for us, but I'm sure it's there. So yeah, so that was, so we can see that, yes, these are what we prioritize as an organization. And I'm just curious, actually.
Is it because they follow up with a cardiologist if they have heart failure, or in case of like something more acute, like MI?
Say that again, I'm sorry.
Is it because are you not finding it because they follow up usually with a cardiologist?
No, I guess as a community health center, we there are some measures that the federal government says you need to do. So that's the uniform data set that I mentioned earlier, which is they're all HEDIS measures, but that's the small group of HEDIS measures that we are evaluated by. So it's what so they just chose that. They could easily do ACE and other things, but the federal government prioritized these for us. So who knows why? Yeah. Actually, I'm looking at our aspirin. You can see that in May, we were 100%, and in June, we were only 75%. So actually 3 out of 4 for aspirin. So only one patient did not get it. So anyway, well, whatever. But we're doing fine the other months. It's only very few patients. So anyways, okay. That was fun to look at. Let's go back. Okay, I think this is the last question. Which of the following is not a reasonable performance measure for your practice to assess care of patients with diabetes? What would you guys say?
So same thing as question before, but with diabetes instead of heart failure.
Okay.
Oh, tough. I'm stuck between C and E.
Okay. C is longer than E.
Yes.
It is, C statistically is more common than E. So a couple of quick and dirty test taking.
Yes. If you're stuck, you go for percentage of patients.
But for B, do diabetes patients have to go to a pediatrist, or they can do the checkup with a family physician to check
That's a good question. I mean, I guess if it's, I mean, I think they usually do go for like
some.
I know they go to podiatrists for like foot examinations, whether it's diabetic ulcers or stuff. But yeah, you're right. Is it a reasonable performance measure? Is a different question.
The last question was talking about, like you said, Khorram, is the same question as the other one. So I guess the main question is it based on, is it
evidence-based?
Yeah, exactly.
So I'll go with E.
Okay, patient is C saying how many patients that were diabetic had? Okay, so okay, blood pressure and diabetes is like one of those correlated, but also lipoprotein. LDL. I don't know. I'll go with C.
C. What do you think, Mohammed? What would you go with?
Yeah, I chose E.
E.
E? Okay. Let me give it a shot. Percentage of patients with diabetes with 1 or more A1C in the past year. Well, I mean, I think that's reasonable. And then I'll share what my organization does for diabetes as well. B, percentage of patients with diabetes seen by a podiatrist during the past year. That one I'm suspicious about, just because personally, I know they don't have to see a podiatrist unless there's, some issue going on. But for general screening, the family physician can do general screening. And in fact, we use something called the monofilament. Have you guys ever seen that?
Yeah.
Khorram, you've seen it?
I don't believe so.
Let me pull it up. Let me actually see if I can just paste it on here. Hold on. Hang on a second.
To check peripheral neuropathy.
Right. Let me come over this way. Let me get out of here. Let me just get a picture of it at least. Hang on a sec. I think this is worth doing. Images, monofilament. There it is.
We can't see your.
Yeah.
Oh no,
Yeah,
I'm still working on it. I'm almost there.
okay.
Yeah, still working on it. Ah, goodness. Why is it not?
Is this stuck, doctor?
I'm sorry?
Is your screen stuck?
I don't think so. No, I'm working on another. I'm going to Google. I'm trying to copy it. I'm trying to copy the image.
Okay.
I'm just having some difficulties with that. Hang on a second. So I should just copy the image. There we go. Okay, let me see if I can just paste it here. I just want you to see it. There it is. This is a monofilament right here.
Mm-hmm.
You see it, Horam?
Yes.
Okay, this is a monofilament test. This is flexible. I mean, it's almost like a wire almost, but it's plastic. It's straight, but you know it's easily bended. And then oftentimes it's attached to this like thin cardboard or thin paper. And you can see it says ADA diabetic foot screening, and it even kind of circles where on the foot you can test for sensation. So what you do is you take the monofilament and you apply it to the feet. Okay, you apply it to the feet, but you apply maximal pressure prior to it bending. So you apply as much pressure without it bending, and you see if the patient can feel it. If the patient can feel it, then that sensation, if they can feel it normally, then that sensation is intact. So that's the monofilament that you can use as part of your physical exam to screen for peripheral neuropathy. Okay? And what you can always do, Horam, is you can always, and Mohammed, you could just YouTube a quick demonstration of it actually after we're done. But this is the monofilament. So for me, I'm like, well, you don't need to go to a pediatrist for this,
Okay.
you know. So that's why B is a little suspicious to me. So C, percentage of patients with diabetes who had their blood pressure documented in the past year to be less than 130/80. So here's how I feel about this one. I personally don't use this, but if you think about what does the medical community say? Some, you know, I think if they have proteinuria, okay, if they have proteinuria, then it's this. But what if they don't have proteinuria? Is it 130/80? Well, some people might say yes, some people might say no. So for the thing is, if there's some debate or controversy or conversation about it, that's different from people definitely say no, okay? So there's a difference there. D, percentage of patients who received a retinal or dilated eye exam by an eye care professional during the past year or during the previous 2 years if the patient is not at risk for retinopathy. I mean, that sounds reasonable to me.
Yeah.
C, I kind of question. B, I kind of question. E, percentage of patients with most recent LDL cholesterol of less than 100. Also, that's kind of debatable too. So for me, I would take out A and D. B, C, and E are like, okay, you can argue about it. But you know, for me, you can argue about C and E a little bit more than B. Yeah, for me, B is like, yeah, dude, I don't know many people that say to do that for everybody, for all diabetics. So for me, it's like, sure, you can argue about B, C, and E, but B is less gray. So that's why I might do B. And also, if it's C and E, not everyone has to agree for it to be reasonable. Like, other people can do things that are reasonable. Maybe I wouldn't do specifically, but it doesn't mean it's not reasonable. Okay?
Yeah.
So that's kind of how I think about it. So if somebody wants to do something a different way than mine, it may be very reasonable, but for whatever specific reason, I might do it differently. That's fine too. Mine is reasonable, theirs is reasonable. Okay, let's see what the answer is. Answer is, that'd be funny. Khurram, what did you say?
I had said C.
See? Mohammed, what did you say?
E.
Wow, we're all different on that one. Let's see.
Yeah.
Let's see what we got. Answer is.
But we all agreed that the feet checkup, no need for podiatrist.
Yeah.
Right.
Family physician can do it.
And by the way, the question is there evidence behind it? Oh, by the way, the other thing in family medicine in general, anything that says, oh yeah, make sure you send to a specialist right away. Always a little skeptical on that. Yeah, always kind of be wary about that. And then think about it. Is there ever a guideline that you saw that said every diabetic needs to go to a podiatrist?
No.
You have to, I mean, on its face, it sounds like it might be reasonable, but if you think about it, have you ever heard of that? I don't know if I have, but have you heard of, guidelines suggesting that blood pressure should be less than 130 over 80 or we have, you see? All right, guys, answer is B in this case.
Okay.
Let's see what it says. Although proper foot care is important for patients with diabetes, there is no evidence that an annual visit to the podiatrist reduces morbidity in patients with diabetes. Other measures listed are reasonable and approved by various organizations on the basis of effectiveness studies. And I like that answer because it acknowledges that for C and E, it acknowledges that, other organizations, maybe not every single one, but, and I think A, pretty straightforward. I mean, yeah, how can you not get an A1C? And then D, that one is pretty straightforward. I mean,
think so because only an ophthalmologist could do the dilated, I guess, or retinal.
You bring up a good point. You're bringing up a good point. You're saying eye care professional. Yeah, it's a good point. But I think for this one, in practice, all family physicians can use this thing. But for the dilated eye exam, to check for the retina, that one is maybe more so you need either optometrist or ophthalmologist. So
yes.
Yeah. Okay. So now let's see what our organization does for diabetes.
Yes.
Let's see our measures is interesting. It's not. I'm interested to see what you guys think about this measure. Let me find it. Okay, here's where I found the monofilament image.
Mm-hmm.
Oh no, that's the wrong app. Sorry, one moment.
Oh.
Where is it? Oh, I don't know. Oh, you guys, I'm really struggling here. Let me see. Okay. Where is it? Safari. Oh, there it is. Okay. Okay. All right. So this was our aspirin. Let's go to our diabetes. So here it is. It's diabetes. This is a measure. This is very interesting, actually. I wish our measure was like the other one, actually, to be honest. But no, this is actually a little bit different. This is your percentage of patients with either a hemoglobin A1C of over 9 or they do not have a recent A1C. So that's
so you want a low number for this, right?
You got it, Khurram.
Okay.
I'm proud of you. I'm proud of you. You want a low number for this one. Yes.
This is not the one you want 100% on.
No, this is, you want as low as possible. the computer is thinking here. Let's see, how did we do for this? Let me see how we did for the quarter. I just hope it got better. Please, Lord. Oh, God. Yeah, it got a little better. Yeah, a little better. Okay, got a little better. Okay, so the network average, our network average was 30%. Our organization is like 40%. So yeah, so these are patients with, these are patients with, again, like you said, Horam, the lower the better. They have an A1C of over 9, and they're, or they don't have a recent A1C. So this is kind of how we're doing. So what do you think about that measure?
Well, just to confirm the data, so when it says there's been an 8.8% increase in the baseline,
Yeah.
does that mean
Sure.
there were more patients that had 9 or higher or were untested?
No, it just means that I changed it from from just the previous quarter. So the previous quarter, our percentage was 48%. And then this past quarter, it was 40%. So it got better by 8%. So our measure improved by 8%.
And there's no way for you to tell just through this data of like how many people were not tested?
You know, that's a good question. We can go, so the answer is yes, we can, yes. So basically, if we go to detail list, we're able to pull up all the patients. So we're able to pull up all the patients, and we're able to see who got an A1C and who didn't. So you are correct, Horam, and your point, I believe, is a very good point, because I feel like what you're sort of pointing to is to say, well, my goodness, Dr. Murad, why don't you just make sure that the ones who don't have an A1C, let's get them in and make sure we get an A1C. And that's that would be the basis of a good intervention for us to do. So we have some interventions, maybe for someone to just, and actually we do, now that you mention it, we do have someone who goes through the list that calls patients to bring them in to get their A1C. So. And
I guess you did say, doctor, you had a nutritionist on staff or a dietitian?
No, what we have is we have behavioral health clinicians. So the behavioral health clinicians can help counsel patients on to talk about strategies for embarking on a healthy lifestyle, which includes a change in diet. As far as the specifics in diet, they may touch on that, but not so much go into depth. Their role mainly is to sort of guide patients through how to implement a meaningful lifestyle change.
Okay. So I guess the best way I guess people that needed to be tested for A1C that were not included, they should be tested, as well as I guess making plans for patients that were on the higher of A1C level, how to lower, like whether they're using their insulin properly or not,
right, or
at the correct timings, and maybe it's just they're still eating very bad.
Right, exactly. Yeah,
I think that's tough because it's multifactorial and it's not just one thing. Yeah.
And I agree with you. I think for me, this measure, it really incorporates outcomes. It's actually very interesting. It incorporates, one part of it incorporates an outcome. The other part incorporates a performance. If we look at those answers, those are all very much performance measures. Did you get an A1C? Did you do a foot exam? Did you send them for an eye exam? Although I will say that the blood pressure measure is kind of like an outcome, or an intermediate outcome. LDL less than 100 is sort of like an intermediate outcome as well. So it's not so much, are you on a statin? It's, what is the LDL?
Okay.
With the blood pressure, it's not so much, are you on a blood pressure medicine? It's, what is your blood pressure? So with the diabetes, I feel like they tend to incorporate, like they start to put in the outcomes. And actually blood pressure is the same way.
Yes.
Our hypertension measure is the same way. It's not so much, are they on an aspirin? Are they on a statin? It's what's their blood pressure. That's why these measures tend to be tougher. Yeah.
And how often are diabetics tested for A1C usually, doctor, at your clinic?
Well, so basically, if a patient is well controlled, then you can get an A1C every 3 months. So that's just the medicine of it.
Okay, that's
The clinical practice is to say just get it every 3 months. Okay. Now, and actually, I should add that a lot of times when they're well controlled, clinical practice for a lot of folks is every 6 months.
Okay.
To be honest, I recommend personally every 6 months, but every 3 months at a minimum. Now, so if they're uncontrolled, it should be every 3 months at a minimum if they're uncontrolled, okay? If they're controlled, you can space it out to potentially every 6 months. Now, in order to improve this measure, what a lot of other organizations, you see kind of a comparison of all the organizations in our network. What a lot of organizations are doing is they are having patients come in every month for an A1C so as to improve their control, okay? And I think that is really where we need to go. And that's where we have started going, actually, is having patients come in every month. So as to, again, improve that control. So, so that is not in any practice guideline or any clinical guideline, but that is what seems to be helpful locally in our states for improving this measure.
Okay.
Yeah. All right, guys. Mohammed, what do you think of this measure?
No, in your sorry, your percentage, I mean?
Yeah.
Yeah, it's really good. Just as Horam said, if you can follow up with people who didn't measure at all, that would be perfect to reach the highest percentage.
Yeah, I think so. So, yeah. Okay, guys. Well, I think.
Doctor, do you do in-house testing, or like for the blood test, or you send it to a lab or something, or is it done in the?
Excellent. Yeah, excellent question. We do in-house testing.
Okay.
That's an excellent question, and that makes it easier.
Yes, definitely.
Yeah.
Okay, that's good.
Yeah. So yeah, we definitely use the in-house testing. So. And with the in-house testing, you have to make sure you have appropriate quality controls on it. Like, we got to make sure the machine is calibrated and all that. So, yeah.
Okay.
So I will say, if we take an honest look at us, we're second to last in our network. I think cervical cancer screening, we were like second best. But this one, we're second to last. So honestly, we definitely have a ways to go. So we definitely need to keep working on that. I see here if we can break 20-something%, that would be really good. We have some organizations that are even less than 20%. So we got a ways to go on this. So I appreciate you guys' sort of
motivating.
Yeah, your insights and your impressions. So. All right, guys. So I think that about wraps it up for today. You guys have any questions before we sign off?
Yeah, that'll be it, doctor.
Okay. I will sign off, and I'm sending you the link. Okay.
Thank you, Dr. Morocco.
All right.
Take
Very
care.
good.
Before we leave, did you have any Panera bread today?
Panera? No Panera yet today. No, maybe a little bit later.
Okay. All right, doctor. Thank you.
All right.
Have a good day.
You guys have Panera in New Jersey, right?
Yes, we do.
Do you have Panera in Beirut, Mohammed?
I wish maybe when I come to the US.
Oh, yeah. We do visit it. So, all right, guys.
Have a great weekend, doctor. Thank you.
Thank you, guys.
Thank you. Bye.
Thank you. You're welcome.